Kia ora, welcome to the New Zealand Sim Nurse NZ podcast. My name is Erin.
And I'm Alison.
And I'm Marie.
We are the three nurse educators from the Douglas Starship Simulation Programme based in Auckland, New Zealand. We're all passionate about our work, and so we'd like to welcome you to join us as we have a range of conversations about all things sim.
Tēnā koutou, tēnā tātou katoa. Kei ngā maunga whakahi, kei ngā wai tukukiri, kei ngā mā tawaka o te motu, ka nui te mihi ki a koutou. To those who connect to the mountains, the rivers and oceans across the land, hello and welcome to you all.
Welcome to our next episode. So today we've got Dr Khang Hee Gan, who we've all worked with, or had the pleasure of working with, to be honest. He was our Sim Fellow for a little while, and we'll let him introduce himself really. So Khang, do you want to tell us a little bit about yourself, a little bit of a career bio if you like?
Yeah. Thanks, Erin, for the introduction, and thank you for having me over here. It's a pleasure to be here today. My name is Khang Hee Gan. I'm a Paediatric Emergency doctor in Starship Children's Emergency in a little city in Auckland in New Zealand. I'm an enthusiast of simulation-based education as well in my free times, and I enjoy working with every one of you. So I graduated from medical school in 2009 and sort of fell in love with pediatric emergency early on in my career and decided to pursue that career. And throughout my training, I was exposed to simulation-based education as a learner myself. And sort of that inspired me throughout my training to be an educator myself. So I qualified as a pediatric emergency specialist 2 years ago, where before that I worked with the simulation team and the children's emergency team as the joint pediatric simulation fellow. Following the completion of my training in pediatric emergency, I did a post-training fellowship in the Hospital for Sick Children in Canada, where I pretty much did the same thing. I was the pediatric emergency fellow and the simulation fellow as well. Cool. I came back to New Zealand a year and a bit ago to take up a permanent position now as a pediatric emergency specialist in Starship Hospital. So that's a kind of not so quick summary of my career.
And we're very grateful to have you back.
Yeah, absolutely.
Good to be back.
Yeah. So I guess that probably we can roll into the Sim Fellowship stuff. So what's the biggest thing that you think you learnt as your time as our simulation fellow with us at the Douglas Starship Simulation Programme?
You can't see breaking mannequins.
Yeah, well...
You did have a habit of breaking mannequins.
Yeah. We won't talk about the breaking of the mannequins.
Was it the time where I had some water, underneath the skin of the mannequins? Yeah, maybe.
No, I think that was probably us.
I mean,
okay, it's you. I blame it on you.
There's been a few boo-boos.
Yeah. Yeah, you know what? I actually learned a number of things, but I think the biggest thing that I learned as my time as a simulation fellow with the Douglas Starship Simulation team is basically to be ready to pick up a new challenge that you weren't expecting maybe a year or two ago, and being really opened to new challenges. I always told myself that I had some interest in simulation from the early part of my career, and I wanted to be a instructor in simulation in the APLS course, or in the Advanced Pediatric Life Support course. So that sort of lead on to me, when I was working as a pediatric fellow in Whangarei. I told myself I have to, get immersed in simulation, so we created regular simulation in a pediatric ward. And sort of when I came back to New Zealand, when I came back to Auckland as the Starship Emergency Fellow, I was offered a position in the Douglas Starship Simulation Programme as well, which wasn't what I was expecting at that time. I know I really like simulation, but I also wasn't expecting to be offered that position. I wasn't aware that there was that position. So, but I sort of thought it was a good chance, it was a good opportunity. It was something that I wasn't expecting, but I decided to take it and see how it goes. And what I've learned since then is if you give your chance the opportunity, if you give yourself the opportunity to be open to various different challenges, it opens up a whole lot of different pathways for you. So from my time in the Douglas Starship Simulation Program, I then went on to realize that there's a whole lot more of simulation fellowship around the world.
Yeah.
I was able to apply and then be accepted to the job in Canada, and sort of I was encouraged as well to be a fellow in the IPSS Inspire International Simulation Fellowship. So that's for the listeners, a kind of a relatively new international fellowship that we're doing. So it's been in existence probably over the past 3 or 4 years. So I was one of their fellows for a year and a bit, and it sort of opened up the opportunity for me to be involved in the wider simulation world as well. So since then, I've been involved in the fellowship committee as well as one of the co-chairs, and I've had the opportunity to be involved in different networkings as well around the world, in terms of pediatric simulation. So it's a kind of a roundabout way to say that you should be open to accepting challenges that you may not be expecting, and it'll open up a whole lot of opportunities for you.
Yeah.
Cool.
And just for anybody that is unaware, IPSS is the International Paediatric Simulation Society, which we're all members of. It is worth going onto the website, just kind of checking out. It just opens your eyes to this whole world of simulation that's actually out there. Lots of resources. I mean, we use it frequently. I was lucky to go to the conference, the international conference, when you went there as well, Khang, in Toronto. And yeah, it's fantastic actually seeing this network of people that are all actually passionate about simulation and actually getting it out into the workplace and workspaces. All these amazing people with these ideas, just sprouting out of them, and it's very inspiring. So I think, sort of if you're on your journey into simulation, just going online and looking at Inspire, looking at IPSS, looking at NZASH in New Zealand, there's lots and lots of resources out there of all these people that have these amazing ideas and want to collaborate as well. So I think, it's very exciting kind of place out there. And as you say, you're a fellow out there. So, you've kind of gotten into that network a lot more. So
it's like one opportunity has led to another opportunity and has led on to more opportunities. So it's really exciting. So I would just recommend to everyone, if you're interested in simulation, join a network, join IPSS, join Inspire, or join other simulation networks, or get in touch with us and see what we could tee up.
Get on Twitter.
Yeah, that's for real.
Oh my goodness.
The world of Twitter is amazing. So.
Yeah, the international sim community is so giving and so sharing.
True.
And it just blows my mind, really, the things that we pick up.
Yeah. Cool.
What do you think it was that was the original thing that sparked your interest in simulation?
I think the moment where I decided I wanted to do simulation was actually when I attended a advanced pediatric life support course as a learner for the very first time. And I was really inspired because everything that they taught actually stuck in my mind for a good number of years after that. And I was telling myself, isn't it good? Wouldn't it be good if I can do the same thing and return this teaching, the same inspiration to the general healthcare professional network? So that was the switch to the light, I think, where I told myself I like simulation. There are other things that attract me to simulations as well. So people would sort of imagine simulation-based education as just a different way to give education to healthcare professionals. But what I've learned throughout is you can do so many other things with simulation. And that makes me very, very interested in simulation. So there are quality improvement projects that you can do with simulations. Because ultimately it's about increasing the quality of care that you provide to patients and families. It's not just about the education. The education is a way to get to the improvement of the quality that you give to the patients and the family. You can always use simulation as a way to run research as well, studies that you can't run on actual humans because they might be unethical, that you can run
particularly in paediatrics where the ethics are so strong, you can't use real kids to practice on. So
and other things as well you can do. You can use simulation as an adverse event analysis. There's many other stuff that you can do with simulation. It's also the how giving, as you were saying, how giving the simulation community is. It's like they just want to give you something. They just want to further inspire you and further encourage you to be involved in simulations. And when you see other people who are passionate doing the same thing as you, I think
it's hard not to get inspired.
Exactly. You get even more inspired. Yeah.
Absolutely. Yeah. So when you were in Canada, what was that experience like? And tell us a little bit, because obviously you've brought some stuff back from Canada to us here in New Zealand. But what was the experience in Canada like? As compared to what it was here, because
just to be clear, I didn't bring home any COVID from Canada.
You just had it.
I just had it in Canada.
Please.
Yeah. So
I mean, again, that just that whole experience was so different from what we experienced here. So, but obviously maybe.
Yeah.
In terms of simulation, less COVID, we're trying to.
Yeah.
But
I was there as a emergency medicine fellow for children and as the simulation fellow for the department as well. So it was a really good year professionally, I thought. It really opened up my eyes to what you can achieve with simulations and the various different ways that you can actually provide simulation-based education to a variety of different learners of different levels and specialty. I learned to be open to doing new ways of simulating. When I first went there, I was always thinking to myself, we wouldn't have done that. We wouldn't have done this. This is not how you simulate. But eventually I managed to see that actually it probably doesn't matter that much.
Right.
I think what matters ultimately is whether you succeed in providing education and the quality improvement to the healthcare professionals and to the patients and the family. So for example, they every week there would be almost every week or so they'll be running simulation with the native team who's supposed to be working on the floor as well. So involving physicians, involving nurses, involving respiratory therapists as well, even from doctors from anesthesia as well who are working in another department will come and join the simulation. So I think that I think that's the thing that's stuck with me the most. Having a multidisciplinary team, having a team that's highly realistic in terms of the team that's going to be present when you're managing someone in real life who's sick. Being able to kind of call into them and actually get them to have buy-in, to be involved in your regular simulation. I think that's the thing.
In terms of like logistics, in regular simulation, like was that the same day at the same time every week, or was it like a bit of a fluid kind of?
Yeah.
Because again, we struggle with getting all of those humans in the same room at the same time. So, did they have a set day and time, or how did they kind of make that happen?
I think from memory, they wrote up a schedule for when they'll be doing the simulation, and I think from memory, they wouldn't be the same day of the week, but they would have had an idea of when they want to be running the simulation. Right.
Nice.
There's always, of course, with simulation, with organizing a simulation or organizing something, is the background work that goes with it. So that's another major thing that I've learned as a simulation fellow in Canada as well. So organizing, making sure that people actually attend your teaching as well, being really prepared with them when you're actually trying to organize a simulation. So all the background work put into organizing that, the emails.
Definitely.
It's all about what you do prior to the simulation as well that makes the simulation successful, other than what you do during the day of the simulation as well.
To be fair, I feel like the prior planning takes 3 times as long as the actual delivery and simulation, and even the debrief. It's to do it well and to do it right. Yeah, it's that prior preparation that definitely makes a huge difference.
Yeah, and the other thing I like to say as well, it's the when we're talking about other ways of simulating or providing simulation-based education as well, the other major thing that I learned over my 1 year in Canada was actually the tele-simulation or virtual simulation. How we use the virtual simulation platform to provide simulation-based education during the times of COVID, during the times where there's a need for physical isolation and social, social distancing requirement. It's kind of it's become a very important simulation technique now. Even when COVID, the situation with COVID has changed over the past few months. Yeah.
And I think that's kind of apparent in the literature. I think they said something like 80 to 90% of people had to pivot to do everything online during COVID, particularly in North America. And it's instead of actually going back to how we used to run sim, since COVID, people have actually kind of just stuck with it a little bit more, and they've kind of like, actually, we can see how this platform works. And it's not kind of as bad as we initially thought it was, how can you run sim kind of online? So I think people have, it's in a way, it's one of the positive things to actually come out of COVID. If there's anything positive to be said, is that people have kind of broadened the way that they look at simulation and how it can be delivered. So, it's a really interesting thing, and I think that kind of hopefully leads nicely into what we'd love to hear more about, is virtual resus room, because you've introduced this to our program. It's really opened it up. So do you want to just tell us a little bit more about virtual resus room?
Yeah, so virtual simulation, so at the risk of boring our listeners, and being nerdy.
We're all nerdy around here.
We kind of still need to kind of go through what a virtual simulation is. So just be very clear. Virtual simulation is very different from virtual reality simulation. So
that's a really good point.
Thank you. So virtual reality simulation, which is what we're not talking about, is when you use augmented reality with a headset to provide simulation-based education. Whereas virtual simulation, which we're talking about right now, it's a different sort of platform. So you might have heard of the terms tele-simulation or distance simulation. They're kind of pretty similar, kind of the same similar platform. So basically with virtual simulation, there's a few ways to provide virtual simulation, because basically what you aim to provide with virtual simulation is the learners and the educators being able to kind of come together as a group in the online world, even when they're in geographically different areas of the world. So there's a few ways to do that. So you might have a educator being in a remote position, remote location, managing the mannequin, and the learners actually physically being next to the mannequin. So that's one way to do it. But with that, you need a high fidelity mannequin, and you kind of have to adhere to the social distancing guideline as well, with the learners being all in the same place. But with the VRR, so virtual resus room, it's a way to kind of go around that without having to be physically in the same place. So virtual resus room is an online platform created by two emergency physicians in Canada, so James and Sarah. Basically, what it is it's a Google Slide platform with a vital sign monitor. So just stop me if if I'm mansplaining.
No, you're not. You're not.
Yeah.
Really.
So it basically operates via Google Slide. So on the Google Slide, there's a patient silhouette where you can drag various different equipment onto the patient silhouette. So, for example, you want to be giving oxygen, so you can drag a photo of the nasal prong or the Hudson mask onto the patient silhouette to kind of tell the educator that you have applied an intervention. There's also a vital sign monitor next to it that the educators can change live. So basically, what you do is the educator will share the Google Slide links with the learners, and everyone will go to the Google Slide website, and then they'll run a case, and the case would be almost similar to a in-person simulation, but slightly altered because of the online nature of the simulation, and the changes that the participants make will be applied pretty much in real life. So other participants will see that the changes have been made by another participant as well, by the other team members. So based on the interventions that the participants applied, the educator can now change the vital signs or give them different stamps according to the intervention that's been applied. There are other things that can be used to facilitate VRR as well. So including a photo of a rash, for example, to encourage diagnostic reasoning, or creating a short video loop of a seizure as well, just to sort of add to the fidelity of VRR. So that's basically the platform that I learned in Canada.
And it's also got, so you got your Google Slides open, but you're also got all your participants on Zoom. So the Google Slides update automatically, and you can kind of see who's making those changes on those slides in real time. But you've also got your Zoom sort of banner down the side as well, so everyone's got audio and can talk to each other and do all the teamwork training as well.
Yeah. And you can use Zoom, you can use Skype, you can use Teams, whatever that works best for you. And that's the good thing about VRR. You just have to find a way to communicate online with the other team members and the educators. So we use VRR in Canada because of the physical distancing rule initially when I was there. I kind of went there during the peak of COVID, so we've had to adapt quite quickly to the virtual resus room. So I want to thank the team in Sick Kids Hospital as well for their hard work in bringing over VRR and educating all of us.
And because I mean,
and sharing it.
It's free.
It's free.
Online.
It's online. It's amazing. And
virtualresusroom.com.
And the more that we've got into it, the more we can appreciate the work that they have put into that. It's spectacular.
There's it's been a mountain of work, I think, by the looks of things. Based on their work online. So you can go to virtualresusroom.com and basically there are ready-made cases that you can use for adults, for kids, or there's also building block to make your own Google Slides as well, to make your own virtual resus room.
Yeah.
I think that's what's been very attractive to us.
Oh, yeah.
Yeah, we can use the case, but we can also make our own cases.
Yeah.
How often were you using VRR when you were in Canada?
Very often.
I feel like our very often and Canada's very often might be slightly different.
Yeah. Well, probably at least once a week. There was still there was still some sort of in-person simulation that you had to run, but a lot of it was run virtually in the virtual world. So, for example, we ran some virtual simulation with the local trainees, but we also ran some APLS courses and some sedation courses with various doctors and nurses from around the world as well.
Oh, wow.
And because of the physical and social distancing rule, VRR was very helpful.
Yeah.
We ran the resident and the fellows simulation with VRR. We ran an OSCE. So an OSCE is basically a medical. It's a clinical based medical exam for medical trainees. So we ran that through VRR as well. So
cool.
There was a lot of things that we could run with VRR. But we kind of have to understand VRR. You have to understand the platform and what the platform can provide for you.
Right.
So for example, if you're trying to teach someone some procedural skill, that's when you can still use VRR to get them to describe how you put in, for example, an IV line or an intraosseous cannula. But you can't actually let them do the hands-on thing. Right. So you have to be aware of the pros and cons of the
they can gather
VRR.
the equipment that they might need, so get really familiar with everything that they might need to do that, but they physically can't do anything kind of hands-on in VRR.
It just means that you might have to alter your objective a little bit. So, for example, rather than saying one of your objectives is having the participants do correct CPR at 15 to 2 rates, 15 compression to 2 ventilation rate, you might have to change your objective to having them describe how to do appropriate compression and ventilation. So it's very important that you set your objectives correct. It's very important that you set what you want the participants to learn from this simulation, because VRR can do pretty much 90% of the things that you want to achieve via simulation. You just have to be aware of the limitation of it as well.
I think it's really good to remind us as well that actually, no matter what kind of sim we're doing, having those really specific learning objectives is key. And even if we're doing it in person versus VRR, just being really specific about what you're actually trying to get at, because obviously we need to stay flexible, but making sure that you keep those objectives quite tight is a good reminder.
That's when we need to make a tiny tweak, perhaps, to our our previously written case sheets.
I mean, I think that's one of the things that I really enjoyed when I sort of got my head around VRR, and it did take me a little while, I got to admit, and put my hand up, and I was like, when you first brought it over, I was like, I don't know how this is going to work. you know, it's flat, it's kind of a screen, and, you know, how are you going to get it? But I think from the first couple of times I saw it actually being used, the thing that really kind of struck me was how people were having to talk through their actions and actually explain what they're doing and why they're doing it.
Yeah.
You know, you can't just do something, you had to kind of explain a lot of it. And I think getting behind that thinking processes of why we do what we do was a really interesting part of it. So, you know, I kind of said I could see this kind of really interesting, you know, the people that were normally quiet in a face-to-face sim couldn't be quiet on this. They had to actually tell you what they're doing. They have to actually talk through their processes. So I found that really fascinating and very beneficial kind of aspect of VRR that I didn't expect.
And what you're saying is actually not, it's not uncommon at all. It's actually a very common phenomenon when people get introduced to virtual simulation or VRR for the first time. They always have some doubts about reservations.
It's hard not to. Hey,
Yeah.
like, it's hard not to. It's very different.
So you may have heard me, you know, when I'm running some VRRs, I usually warn them that this might feel a little bit weird for the first one or two cases, but you know, asking them to basically give us their trust that things will actually get better in subsequent cases, and you can actually see that they become so much more comfortable with the technologies and the technicalities around it as the cases go on. So that's very common. And Ali, you've brought up a very good point about VRR as well. So I think it trains us to be a bit more verbal about our thoughts and what we've done in terms of interventions. Because that's why that's one of the reasons that we do simulation. We want to train the teamwork. We want to train the communication during moments of crisis, and VRR achieves that really well.
Really well.
Because you don't get the non-verbal cue that
Yes.
much online.
Yeah.
So you have to be really
Specific about what you're doing.
Yeah, and
Explicit.
verbal.
Absolutely.
Yeah.
And how do you find the debriefing online compared to in person?
There are, I mean, most of the time it's good, but there's always some differences compared to when you do an in-person debriefing. So when I do a debriefing in person, I usually get them to leave all the equipments, you know, you guys do that as well, leave all the equipments on the beds, stop doing things that you're doing, and then gather around a circle. So we need to do the same thing as well when we're debriefing via VRR. Get them to close the window, and then everyone, if they haven't, they should have turned on their video camera, and they should unmute themselves, unless they're at somewhere that's really noisy, that has a noisy background. And sort of just getting them to let go of the simulation and now going to a new phase of the simulation as well at the debriefing phase. But otherwise, you know, the steps that you do when you're debriefing, so the reactions phase, the event summary, you know, the plus delta, or you might want to do some other debriefing with advocacy inquiry. They're still the same. Occasionally, you find that it can be a bit more difficult to engage certain participants, just because of the lack of the kind of the non-verbal cue.
Right.
You lose all the visual and social cues as well when you're online as well. So a participant that is quiet, you know, it can go a few ways. They might talk a little bit more, but they might become even more withdrawn and even more quiet. Because they don't want to interrupt people from talking. They need to unmute themselves when they're talking as well. They might be in a place where there are other, you know, foot traffic as well, other people, so they don't feel that comfortable being debriefed at that time as well. And on the flip side, you might have usually kind of people who are quite talkative, they become quite quiet as well. So it could actually go a few ways. So just being aware of that and maybe warning them beforehand as part of your pre-briefing that you might involve everyone. You might ask certain people specific questions during the debriefing as well, and kind of just giving them the psychological safety that pre-briefing that you're not picking on them because they're quiet. You're just warning them that because this is an education endeavor, we'll try to involve everyone. And the other good thing that we can do during the debriefing online as well is to kind of get everyone at the end of the debrief to get everyone to summarize one thing that they learned throughout the debriefing and the simulations. That way you can get everyone to be involved for one last time. So those are the things that we already do in in-person simulation. It's just more important to emphasize that in virtual resuscitation.
I think I've sort of personally seen, as we've all gotten used to Zoom, I think, at the start of COVID, everybody was kind of using this platform and just like, how do I use it? I'm not too comfortable with it. But I think over the last sort of 2 years, everybody's kind of like, Zoom is just a way of life now.
Right.
And I think you can kind of see participants, particularly on VRR, when I've done it, they're way more comfortable kind of using that platform and knowing when to interrupt and, when to unmute. And, it's not that stop-start that it used to be right at the very beginning, like, oh, you're on mute, So it's like, somebody yapping away and you unmute yourself, So I think it's kind of, it's definitely gotten a lot better from that point of view, and people aren't so kind of hesitant to use a platform like that anymore.
Yeah.
The other thing is you should actually prior to the day of the simulation, a few days or a few weeks prior to that, perhaps send out an email to them as well.
Yeah.
Kind of give them a link to a video of how VRR works as well. You give them a pre-simulation day pre-brief.
Yeah.
That's actually quite helpful as well.
Yeah,
That's what I've
definitely.
found as well. Yeah.
Those slightly less techie people can actually spend some time if they want to practice and to play around, because it is like physically getting your body around, like just doing some skills in medicine. You do actually have to kind of physically practice and get used to the platform a little bit in terms of copying and pasting and moving between slides and stuff. So
and inevitably there'll still be some technological challenge or hiccup during the actual simulation. So
no doubt,
very, very important as well to tell the participants that at any point where you're struggling with the technology or the technicalities, to actually just don't be afraid to yell out for a timeout so that we can actually sort out the technology side of things.
And we've sort of figured that you actually need quite a lot of faculty to run a VRR as well.
It's similar to the big deal sim that we do in person. Hey, like it takes as much. Like it's all kind of the same but different. It takes as many people to run it really well as it does in person.
Yeah.
With ticking and observing and, making sure to give the participants that information that they need in real time and in a sort of time-efficient manner, and, trying to have somebody that can go off to a different slide with somebody who's...
And occasionally you might need the educator to be an embedded participant as well. So you can, you might need a number of faculty members.
Yeah, like it's not any less. And again,
shouldn't be understated, right?
Yeah, exactly. And I think, like, talking about the debriefs, the ones that I've been involved in, although they've been slightly different, they haven't been any less educational or engaged in, or and you can see the experience hasn't been that different to an in-person experience either. So I think it's
a great platform in the fact that you can completely adapt it to your own environment. We kind of totally took what you gave us, and we have basically, I think it took us about 2 weeks, didn't it, in total, just to kind of to get all of our equipment into that
to New Zealandify
platform.
it.
To New Zealandify it, to Starshipify it, to an environment that is familiar to the participants.
It's very editable.
So, if you are somewhere and you're struggling to kind of run those kind of big CRMs with a lot of people. This is a very adaptable platform. And as we say, it is free. So, you can adapt it to your space. And, because people are online, it's not about that kind of, the difficulty of getting everybody into the same space.
Yeah.
If people
So
can
much
only
more
make
access.
2 hours, and do a 2-hour session on Zoom, they can log in, they can get a really good sort of teaching session and a fantastic debriefing experience. So I think it's something, if you are struggling to kind of get those big simulations going in your area, do look into this because it is a very good platform to use.
Yeah, or if you
for
work remotely,
simulation.
work remotely with different groups of people, it's so accessible.
And I mean, even
in
across
Auckland,
even across hospitals,
Yeah,
you
yeah.
could have multiple hospitals
Yeah.
engage in this.
Yeah.
I mean, the options are limitless with it, really.
Yeah.
And it's something we hope to see in the future in our program. We would love to grow it, and if you're interested, please contact us. Because I don't know about you, Khang, but I think it's definitely a tool in our toolkit of sim that's probably going to stay with us. And we're using it in all kinds of settings, such as for community nurses, inpatient, multidisciplinary teams. So, really the options are limitless with it. Yeah.
You guys have made a really good point. So, we've talked so much about health equity, in recent years. And I think VRR are very really high hopes with VRR.
Yeah.
In terms of,
Absolutely.
addressing the inequitable setting of healthcare simulation-based training.
Yeah.
With New Zealand being such a geographically remote, you have some really remote places. I see it as a great way to bridge the inequity in healthcare simulation
Absolutely.
between the big cities and the more rural and remote area. So
100%.
So I think that's the next step that we need to be aiming at. Aiming to involve people, healthcare professionals from very rural area in New Zealand. And then, taking one step further, branching out to international arena. Yes.
How cool would that be?
Yeah, like to sort of areas where there's just kind of less resources for simulation.
Absolutely.
Definitely.
Absolutely.
Well, I know when you came home from Canada, Khang, you were doing some 3 a.m. VRRs. We busted you looking a bit tired, and you're like, I've been doing VRR all night.
Try to limit myself from doing that nowadays.
And when we say, you can adapt to your own area, don't be put off by that. If I can do it, like literally anybody can do it. I am the most untech savvy person going, as Marie, who sits next to me in the office, would probably attest to. So the number of times I've gone, Marie, how do I do this? And, so if I can do it, anybody can do it. So it is very adaptable. Just, use your own environments.
Yeah.
Doesn't
And
matter
again,
where
we have resources that, like we say, we've
absolutely.
New Zealandified, that we're more than happy to share. Some of it is quite Starship specific, but even that we can certainly share and show you how you can make it your own, because it's not difficult. It does take some time.
Just learning,
But once you've got it done, you can then just cut and paste it into all kinds of different things. Once you've done kind of that hard mahi at the start, you can then adapt it into lots of different ways and means. And so, please get in touch if you're interested.
Yeah, please do. And we're starting to present at conferences about it as well. We're going to be presenting at NZ Ash, or we may have already presented by the time this comes out. But we're starting to share this work as well. So please connect with us. We would love to hear from you.
Absolutely.
Yeah. Any final questions, do you think?
Can I just give one final
Of course.
point?
Of course.
Right. I just want to say that I really love the work that you guys have done to Kiwify, to New Zealandify VRR. Like, I've seen the work that you guys have done. It just gives participants more psychological safety, knowing that they're actually in in a virtual simulation with sort of equipments that are known to them, and that's what's present in their actual ward. It just feels much more psychologically safe and more realistic. To use the airway trolley that you're more familiar with, rather than being in New Zealand using an airway trolley from North America. I think it helps with the learning so much better.
There's
Thanks,
subtle
Kang.
differences, but I think they're important, hey? So thank you. Yeah.
Alrighty. So, I guess we can wrap this up, really. We've learned quite a lot about Khang today and all of his experiences as a fellow here in Starship with our team and with the Children's Emergency Department before going on to become a consultant in Children's Emergency Department. We've talked a lot about his why and what's piqued his interest in simulation. And then we've also talked a lot about his experience in virtual resus room and VR settings and learning online. I think it's been a really fascinating conversation. So, thank you.
Thank you, Khang.
Thanks for having me here.
Thanks for listening to this episode of our podcast. It was made possible by the Starship Foundation and the Douglas Charitable Trust.
And special thanks go out to all of our amazing guests, and especially our producer Carl Thompson from Blue and Ginge Creative.
If you'd like to connect with us on Twitter or find out any information from any of the episodes on this podcast, just see the show notes.
Our Twitter handle is @StarshipSimProg and our email is starshipsim@adhb.govt.nz. We would love to hear from you.